All right, hello everybody. I'm going to talk to you a little bit today about a clinically available test right now, which is used to help you as a clinician identify patients who might have a higher risk of metastasis from squamous cell skin cancer, called DecisionDxSCC. My name is Jason Newman. For those of you who I don't know, I'm currently a professor at the University of Pennsylvania. I run the cancer service line. I'm the director of head and neck here. And this is being given as part of a series through the American Head and Neck Society. You can see my disclosures listed here. So with that, let's go ahead and get started. So I'm gonna kind of hit a few topics today, but this is an outline of what we're looking at. So we're going to talk a little bit about cutaneous squamous cell carcinoma, what DecisionDxSCC is, talk a little bit about how we got to understanding of how this gene expression classifier works, what the intended use population is, and then flipping to kind of using it to help predict metastasis, both in non-head and neck as well as in head and neck cancer. Finally, talking a little bit about clinical considerations, meaning how do you take this information and apply it to your clinical practice? And then finally showing just a few case studies just to give you an idea of what we're talking about. So I know probably most of you in the audience already know this, but cutaneous squamous cell carcinoma is a big and continuing problem. As most skin cancers are, the numbers are going up over the last few years and probably aren't going to stop going up for a long time. As you also know, it is the second most common type of skin cancer, right after basal cell cancer. And the reason that the numbers are kind of averaged is because the nccn does not collect data on every single cutaneous skin cancer. So unlike most other cancers in the body, cutaneous squamous cell is often treated in small places where they're not collecting data. So it's about 1.8 million a year. Obviously very common on the head and neck. In fact, that's the most common subsite for this cancer. We know that several percentage of patients who develop this cancer will develop metastasis. We also know that that is more common in the head and neck because of the rich lymphatic drainage in that region. One of the things that I'd like to point out, because of course everyone knows that melanoma is a terrible cancer and is bad, but if you look on the chart to the right here, you'll see that the actual number of deaths per year in the United States is higher for cutaneous squamous cell cancer than it is for melanoma, which is purely related to the total numbers, right? So melanoma is much less common. The percentage of patients who die is higher, but really, if you think about the number of patients who are dying of skin cancers, the total number is higher for cutaneous squamous. So clearly that means that there is an unmet need, so an unmet clinical need, which is kind of what I'm going to talk about right now. There are multiple staging systems for cutaneous squamous cell carcinoma, the AJCC, the Brigham and Women's Health, the nccn. They all follow mostly the same general types of patterns in terms of helping to determine T stage and N stage, but everyone knows that they are not the most capable at predicting outcomes. They have tweaked the systems quite a bit over the last few years. I'm going to talk a little bit about that in some of the next slide. But just taking a look at these staging systems, it's important to realize a few things. Number one is that a lot of physicians, especially in the community, are not actually using these staging systems. They're using some of their clinical experience or their kind of guts to decide what to do with patients. And secondly, it's important to realize that each of the staging systems actually has their own strengths and benefits and weaknesses, and people aren't using them the same way across different practices. So again, really important to understand that. In terms of how we assess the risk related to metastasis or other events, it's really a pretty broad definition. Depending on who you talk to, and again, also depending on the criteria that people are using, you can look at them in a variety of different ways. So if you are looking at broadening the criteria for how you determine risk, you can see on the left side of this chart, really any high risk area, any moderate risk area, and any patients who might fall under the appropriate use category for Mohs are potentially considered high risk. And if you're trying to really narrow in on those criteria, find patients who maybe have a higher positive predictive value of having an event like a metastasis, you can move all the way to the right side and appreciate that a T2B stage from the Brigham and Women's Health really increases the chance that those patients will have a negative event. All of that being said, though, there's two really important facts to realize. One is that even when patients are staged appropriately, over 30% of cases, it fails to identify over 30% of cases who will go on to develop a metastasis. So what that means is that there are 30% of the patients who go on to develop a metastasis were not called high risk at the time of their initial evaluation. And on the exact flip side of that is the opposite problem, which is that over 60% of cases that are called high risk actually do not develop metastases. So knowing that there's that gap between patients who are not called high risk but end up having a problem, and the patients who are called high risk but don't end up having a problem, that's really where the some of that sweet spot is for helping to determine what we should be doing in that patient population. So if you take a step back for a minute and look at what the DecisionDxSCC is designed for, its intended use is for patients who have at least one high risk factor related to their cutaneous squamous cell carcinoma. So the good news is, for those of you who are head and neck surgeons, there's not a lot of things that you need to memorize, because as you can see here in highlighted in yellow, if the tumor is located anywhere on the head and neck, they by definition already have a single risk factor that makes them eligible for using this test. So, you know, I can kind of end this graph right there. Literally, head and neck location is a risk factor that puts them in a category where it's reasonable to consider using this gene expression test to help predict metastatic disease. There's obviously, you also see there's a laundry list of other potential reasons why people would end up on that in that category: aggressive histology, significant depth, poorly differentiated, lymphovascular invasion, again, a whole host of other things. But for the sake of understanding who this test is used for, if they are a head and neck patient, they are a candidate for it. Just to give you this is a global sense of what a test outcome looks like. So you have a patient who has a squamous cell carcinoma with one or more risk factors. You send the pathology off to Castle. Essentially what happens is that they do a quantified expression of 40 genes using RT-PCR. A validated neural network is used, and it then categorizes patients into one of three categories. Either class 1, which is considered low risk. Those patients have a very low chance of metastatic disease. Class 2A, which is considered moderate risk. And then finally, class 2B, which is really a pretty high risk, over 50% risk of metastasis. So I'm going to back into this a little bit, but I just want you to get a sense of what this looks like at the kind of highest level on the clinical side. So really what happened is a validated cohort was used during a prospectively designed IRB-approved trial. It includes 33 centers in the United States. And these are all patients who had known outcomes related to their squamous cell carcinoma. 420 patients total. They had formalin-fixed tissue sent for evaluation, both from the primary site as well as from metastatic sites if they had them. And then all of the clinical pathologic data was evaluated. The study group was then applied to a cohort in order to validate the results. You can see some of the metrics or the characteristics of the patient population. Most of them ended up having surgery. A lot of them were with Mohs micrographic surgery. The metastatic rate was 15%, a relatively short median time to metastasis, which is not unexpected. And of note, about 66% of this cohort had head and neck locations as a tumor. A quarter of them were immunosuppressed. So a pretty wide variety of tumor and patient outcomes were inputted into this attempt to create a gene expression. And you can see here the Kaplan-Meier curve that is an estimated metastatic-free survival. Again, for the entire cohort, as I mentioned, about a 15% metastatic risk. And you can see how the different classifications laid out. So in a patient who was determined to have a class 1 GEP, gene expression profile, they ended up having a predicted risk of less than 7% of metastasis. So that's less than half of the general population, as you can see. If they were class 2A, 20% risk. So again, and I'll go into this in a little more detail, that number is about as strong as any individual risk factor that we routinely use. And then finally, for a class 2B, these are very high biologic risk. There are essentially no other known clinical or pathologic factors that are as capable of predicting metastasis as this is. So high level of prediction of outcomes. And you see the cohort distribution here, about half and half class 1, class 2A, small percent class 2B, again, about what we would expect knowing the biological behavior of this tumor. And these are the accuracy metrics. So you can see 4 separate columns here. The 40 GEP as a class 2A or class 2 in general, 40 GEP as class 2B, and then comparing that to the AJCC and the Brigham and Women's Health statistics, accuracy metrics. You see highlighted here a pretty high sensitivity, relatively speaking, a very good specificity, and a PPV and an NPV that are frankly either consistent with or frankly even a little bit better than for the other staging systems. So really, the accuracy metrics on this are quite good. And this is kind of diving a little bit deeper into the univariate and multivariate analyses. So you see some of the traditional risk factors: immunosuppression, tumor diameter, perineural invasion, deep invasion, poor differentiation. Those are known factors that are associated with increased risk. You see their p-value, but then you also see now independently and in a multivariate analysis, you see that a class 2A result has an independent hazard ratio that increases the known risk. And if they're a class 2B, that is the strongest prognostic risk, 6.9 hazard ratio relative to not having that. So again, very independently prognostic for the risk of metastasis. And again, here's just emphasizing that. So with a class 2A, literally 2.3 times more likely to metastasize. When you add that to the poorly differentiated, 5.3 times more likely. So really high levels. One of the questions that has come up in either outside literature or in a lot of audiences is the question of, what types of patients is this testing being used in? And so on the left graph here, you can see what percentage, what patient characteristic were the patients had relative to the potential intended use population. And on the right, you can see which specific risk factors were included. So 77% of these patients had tumors that were located in H or M, high risk or moderate risk. And you can see, again, going down the list, size greater than 2 centimeters, other characteristics. These were the individual criteria that were as part of the intended use criteria. So most patients had 3 or 4 potential risk factors that allowed them to undergo this test. Again, for the sake of most of this audience, you will have patients who have at least the risk factor of it being in the head and neck area, very likely to have at least one more of those factors. This is just an updated chart showing the newest NCCN risk stratification for cutaneous squamous cell carcinoma. And I'm putting this up here not for you to memorize it or to kind of pick up any of the details, but what has come up recently is the question of, now that the NCCN, this just was released in February of this year, now that the NCCN has this next level of risk that they're calling very high risk, the question is the Castle study still relevant? Meaning, is it still able to predict better than this, for example, the outcome of patients who you otherwise would just be able to use clinical or pathologic features? So I'm going to show you that the data has been applied to that specific test, and tell you right up front that the answer is yes, it still absolutely is capable of this. So this is for the entire cohort of patients who would be determined to be high or very high risk. You can see here that if you divide out patients who are NCCN high-risk cohorts, the gene expression test is absolutely still able to predict metastatic-free survival. And then you see here, even more impressive is even in the very high-risk cohort, still very much a stratification with an excellent p-value, demonstrating that the GEP is very much still in very high-risk patients, capable of telling you, for example, that some patients are still class 1, meaning they have a low risk of metastatic events, and a significant number of patients are class 2B, which have obviously a much higher rate of metastatic events. DecisionDx squamous cell SCC is a test that helps predict risk of metastasis for patients who have one or more known risk factors. And as you know now, there's a class 1, class 2A, class 2B. Those are really the 3 categories that are allowed, that you can use to predict that. It has been validated on a 420 patient cohort of patients where we know the outcomes. And again, you can see here some of the statistics that I think you can use clinically to help judge outcomes. We know that this test will be used in conjunction with all of the clinical and patient risk factors that you are including in your decision making. So hopefully this will continue to evolve as we understand more and more how this may play a role in clinical decision making. And again, we're hoping that this DecisionDxSCC can inform the decisions that are within the guidelines that already exist in the clinical care of patients. So let's move on to the head and neck part of this at this point. So obviously, as you saw from that last bit of data, that was a whole body cohort. A separate set of analyses were run on just head and neck patients in order to help determine if the predictive abilities of this test were able to be translated into the head and neck. Again, IRB approved. It's an ongoing study, 33 different sites. A total of 278 patients were embedded within this part of the cohort. Same general principles were used as in previous, as you saw previously. This is the cohort characteristics. Median age of 71, relatively high rate of metastasis, which again is not unexpected because this is definitively just head and neck, so almost 20%. Obvious known high risk features that were associated statistically with a risk of metastasis, all listed here. This kind of gives you the layout of both the different subsites and the percentage of patients that developed metastasis. I want you to note, however, that the p-value for the rate was not significant, probably partly because just of the numbers, but again, those numbers, you know, on the relative scale are still small enough for us not to use this to say that a specific subsite has a higher risk of metastasis. This is more just a descriptor of which subsites were involved here. So, you know, jumping right into what we saw regarding risk stratification. So you can see how many cases were in each category, very similar to the total cohort, meaning about even numbers, class 1 and class 2A, much smaller cohort in class 2B. But as you look to the numbers on the right for the metastasis-free survival numbers, you see significant differences in the numbers. So 92% in class 1 and all the way down to 44% in class 2B. So again, very relevant for clinical decision making and for clinical evaluations. Again, just the accuracy metrics, similar to the ones that I showed you previously with the same layout. So class 2, class 2B, and then for a sake of comparison, looking at the AJCC 8, as well as the Brigham and Women's, you can see very favorable numbers in basically all categories for the gene expression test compared to the clinical staging system, meaning the ability of this test to help predict the risk of metastasis is quite good relative to any of the staging, clinical and pathologic staging systems. And here, putting that into the, quantifying that in terms of univariate and multivariate analyses with hazard ratios, not very different than in the rest of the body, which of course is generally good, but I want to kind of point out a couple of important things here. First of all, we know that the staging system, so you see on the bottom, the AJCC 8 with a hazard ratio of having a T3, T4, both in univariate and multivariate analysis, has about a 2 to almost 3 hazard ratio. So that's very similar, but independent of the class 2A result, which you see is the blue line, the 307 and the 2.88. But class 2B really almost triples the risk of those events, even compared to the staging system or compared to a 2A. So again, very predictive of risk. So, if you think for a second about what this all means, what is it going to mean? What do we do with these results? Meaning you're seeing a patient, you have a result in your hand, and you are going to tell them what to do, and you realize we don't have any specific guidelines right now for exactly what should be done differently in the management of those patients. So it turns out that a panel of Mohs surgeons, surgical oncologists, radiation oncologists from a few different types of centers really met and started to talk about what decision-making points should be used to help inform clinically oriented decisions for patient care, incorporating the results of this testing. And they basically looked at 3 separate decision points. One was how to look at the nodal stations, nodal evaluations. 2 was to look at the role of adjuvant radiation therapy. And then 3 was how do you incorporate this into follow-up and surveillance. So again, these are obviously early decision-making points, but I think are starting to make some sense clinically to help make decisions about how to incorporate these testing into the routine care of patients. So if you look at which patients, and this is actually one of the questions that I get asked the most by Mohs surgeons, by dermatologists, and even by other head and neck surgeons, when do we decide when to image patients? And even more specifically, when do we decide to do sentinel lymph node biopsies? So if you look at the official Brigham and Women's decision points, you can see that for patients who have advanced stage cancer, so T2B, T3, there is a recommendation to consider baseline radiologic imaging of the nodal bases. So for the head and neck, obviously that would be a CT of the neck with or without contrast, potentially a PET scan. Again, not very well defined which one, but something in that category. Sentinel lymph node biopsy is something that is considered, certainly not done routinely, even in this setting, but it's a discussion point at the level of traditional factors. One of the things that might be considered or that has the potential to be have some clinical utility is thinking about it by adding the results of the DecisionDxSCC into this discussion. So potentially for patients who have a class 2A or class 2B result, you might want to definitively consider baseline radiologic imaging. That kind of takes, that puts us into a category of knowing that that patient has a relatively high risk. Certainly adding that into the equation of the Brigham and Women's Health staging system or other staging systems makes sense. And then even more aggressively, because again, putting a surgery onto the table, like a sentinel lymph node biopsy, we know kind of increases. We want to do that only in the highest risk scenarios, because those patients presumably either have negative scans or a negative exam already. But if they have a class 2B result, we know that that statistical chance of them having a positive node is pretty high. It might make sense to be aggressive enough to actually consider a sentinel lymph node biopsy. So that's kind of category 1 here. How to apply the test to add the role of adjuvant radiation therapy. So again, we know that traditionally there are guidelines that recommend adjuvant radiation therapy for patients with advanced stage cancers, patients who have extensive PNI, positive margins, patients who have a positive lymph node. I would say most of those are not tremendously controversial, but the question is, can we take this knowledge and this information to another level? And so the question is whether a high risk result like a class 2A or class B, should that be used as a reason to even consider potential referral to a radiation oncologist, despite potentially other risk factors, or certainly when you're including them with other risk factors. And then maybe on the flip side, even consider in patients who don't have other potentially high risk features, if they have a class 1 result, maybe thinking about not including adjuvant radiation therapy in those patients. And some of the data that stands behind that is very much in the category where this makes sense. So We know that in patients who have a class 2A result and also have a high Brigham and Women's staging, that involves a 36% risk of metastasis. And if you throw on top of that a class 2B result, those patients probably have a near 50% risk of metastasis. So if you are treating those patients as primary site only and not adding adjuvant radiation therapy, you're thinking about a 50% chance that you're missing all of the disease. Same type of approach with things like extensive PNI. We know that the reason that we're giving radiation to those patients is because they have about a 30 to almost 40% risk of metastasis. It doesn't make sense to not think about that in the same category for a high class, like a class 2A or class 2B result. So really, when you're starting to look at a metastatic rate of in the 20 to 30% range, if you are not treating that with something like surgery, the idea that a positive result from the gene expression profile would maybe make you lean towards radiation for that patient starts becoming a very reasonable consideration. That's one of the goals of this test, is to help you manage outcomes differently. And then finally, follow-up and surveillance for these patients. So we know that a lot of patients who have very small cancers, and again, as the community of head and neck surgeons, we're not always the ones seeing these patients. But when you think about the 1.8 million patients that are developing cutaneous squamous cell carcinoma, many of them are 5 millimeter lesions on the arm. Clinical follow-up for those patients very much makes sense. For higher risk patients, so when you start thinking in the 20 to 50% metastatic risk range, the recommendation is generally follow-up, ultrasounds or CAT scans yearly. And then finally, for the highest risk patients, usually more frequent evaluations and scanning is very much reasonable. So that's the traditional approach. If you think about how you would potentially incorporate the results of the gene expression profile, the decision points are kind of listed here below. So for patients who have low risk profiles, you would still put them in the category of clinical follow-up alone. For patients who have class 2A and class 2B, at least one time a year ultrasound or scanning of some sort. And then for class 2B, definitively more frequent follow-up, more frequent scanning and ultrasounds. And especially for a group who are practicing head and neck cancer, those are the patients that really need to be followed often by more than just their Mohs surgeons and their dermatologists. Those are probably the patients where you shouldn't lose those patients to clinical follow-up. We have patients who see us who end up having low-risk lesions. I always struggle with, do I need them to see me, or can they just follow up with their Mohs team or their general dermatologist? But these higher risk patients probably warrant a thorough exam by someone who is used to looking for regional adenopathy. So again, just in a conclusion of that part, the three separate areas: nodal evaluation, maybe consider using radiologic imaging to check for metastasis, and even thinking about sentinel lymph node biopsies in the highest risk populations. As it relates to adjuvant radiation therapy, thinking a little bit differently about which patients should or shouldn't be sent for treatment. Certainly if they're class 1, it might be, especially if you're on the fence, it might be reasonable to not radiate. Patients who are in that higher risk category, makes sense to really think about it, especially if their risk falls into the same category as the risk that would cause us to think about ART for perineural invasion or for other risk factors. And then finally, just follow-up and surveillance. I think, again, knowing that this is a very diverse population, this squamous cell carcinoma, trying to do a better job of dividing them into the patients who really need close follow-up and the patients who probably could get just clinical follow-up. So I think that really clearly makes a difference. I'm going to end with just a comparative set of cases that, knowing full well that showing, 1 or 2 cases clearly does not represent the entire whole. But I think this is really a perfect example of how this test can come into play in clinical use. So I want you to note that these patients were part of the archival validation cohort. So meaning we did not have the results of their study of the gene expression study until after the fact, but just good examples of how that type of data could have influenced outcomes. So you see pretty similar cases, 60s-ish-year-old men, both solid organ transplant recipients, similar size lesions, both poorly differentiated, both staged importantly as a T1 by AJCC and a T2A by Brigham and Women's. So again, looked at similarly as pretty straightforward lesions, really potentially a lower risk, except of course for the transplant part of it. So you see this is the first patient. He was treated with Mohs surgery, determined initially thought to have negative margins, but a small focus of squamous cell carcinoma was found on subsequent analysis. Again, poorly differentiated, we know that. He declined further treatment. Again, wasn't my patient, I don't have the details on that, but declined further treatment. Ended up doing fine, recurrence-free for the remainder of his life. Unfortunately, died of other causes, but again, no evidence of cancer at the time of his death. Ultimately, looking at the risk stratification category, he ended up as a class 1, which now that you've heard how he did, probably sounds like it lines up pretty nicely. You maybe would have been able to predict that or expect that. This is that second patient, again, also treated with Mohs surgery, only needed 2 stages. So unlike the first patient who needed 4, sometimes that would potentially lead you to believe like it was a much more poorly defined tumor on the first patient. But again, this patient only required 2 stages, no residual tumor, also poorly differentiated. And you can see here that third picture on the right, he developed both a local recurrence and a regional metastasis at 3 months and ultimately succumbed to this specific disease, to this squamous cell carcinoma. The result of his DecisionDxSCC came back as a class 2B. Again, this is information that was not known at the time of his treatment. But of course, here you see the question is, would adjuvant treatment have been appropriate in the patient if that kind of information would have been known? Might if it had altered his progress? So again, as you can see, starting off as similar patients, adding that little information on the bottom here, knowing that if both of these patients had been seen, had the GEP done on them at the time, the question is, would something have been done differently to these patients? Is there a chance that we would have recommended radiation or closer follow-up or some combination of things to that case number 2? I think that's really the sweet spot for this type of test. Can you put it into clinical use in a way that allows you to alter the treatment for the patients who you otherwise would be treating as very similar? In conclusion, really, this test can help categorize patients into various levels of metastatic risk, class 1, class 2A, class 2B. We know that the accuracy metrics are quite good. Specifically, the specificity and PPV of a class 2B were actually improved compared to the clinical and pathologic staging systems. And that this test actually is independently prognostic compared to the clinical pathologic risk factors. So really the thought is that this 40 GEP can actually complement our clinical way of assessing risk for patients, allowing us to make better decisions in the management of their care, obviously with the hopeful goal of creating improved outcomes in this entire population. So I think with that, I am done. I really appreciate everybody's paying attention. You see here my email address. I'm happy to respond to texts and emails. And again, thank you for your participation.